training program, and I am chairman of the ethics committee for National Institute of Cancer Prevention and ICPR, which is ICMR Institute. So every year we get the training refreshed. So all the members have to be trained by their committee. These days they are doing online training, so you need not go there, and online training for about 3 hours, and that is sufficient. And then based on that, they will give you the permission and registration.
Thank you, sir.
Thank you.
So now I would like to invite Professor Devashish Biswasji to give his talk titled The Ayurveda Window in the House of Medicine. Professor Biswas is currently heading Department of Microbiology at AIIMS Bhopal, and his academic achievements include FRC Pathology from Royal College of Pathologists, UK, MD Microbiology, and PDC Laboratory Immunology. He is the recipient of many prestigious awards and fellowship, such as DHR HRD Fellowship from University of Cambridge, UK, Fulbright Nehru Senior Research Fellowship, Albert Einstein College of Medicine, New York, Young's Investigator Award, Department of Biotechnology, Government of India. He has more than 29 publications in the last 5 years and is an editorial member of the Journal of Lab Physicians. And he is also reviewer for several international peer-reviewed journals. It's an honor to have you here, sir. We welcome you.
परम आदरणीय स्वामी जी महाराज, मैं एक डिस्क्लेमर के साथ शुरू करना चाहूँगा। इन ज्ञानी आयुर्वेद आचार्यों का बीच में मैं बिल्कुल एक नॉविस हूँ। So when the invitation came from Dr. Anurag, उन्होंने पहला सेंटेंस ये बोले कि पतंजलि विद्यापीठ में आपको इनवाइट किया जा रहा है to talk on Ayurveda. It was like talking to the sun about sunshine by a novice. Second sentence उन्होंने कहा कि Professor Y.K. Gupta, who is the president of the institute I come from, he has given your name. So I thought that now the summon has come from the Supreme Court. But Swamiji, I belong to the old school. तो मेरा एक inherent tendency है to accept what the seniors say. तो मेरे को लगा there must be some good behind this instruction. So the third sentence I talked to Anurag ji was, Swamiji, I also come from an ashram background. Right from the age of 10 years, I was in a residential ashram in West Bengal. तो मेरे को एक लगा कि वो जो एक inherent good behind the instruction वो शायद आ गया। तो मैंने उनसे बोला कि क्या मेरे को आश्रम में रहने का मौका मिलेगा? He said हाँ वो हो सकता है, but होटल में अरेंजमेंट है। तो मेरे को लगा कि वो भी हाथ से गया। तो कम से कम महाराज अगर नेक्स्ट टाइम हो सके तो आई वुड लाइक टू स्टे इन द आश्रम। तो एनीवे तो मैंने एक हिम्मत जुटाया। इट वाज अ डॉन्टिंग टास्क टू टॉक ऑन एन आयुर्वेद बाय अ नॉविस इन पतंजलि, बट मेरे को लगा कि अगर गलती करना ही है तो गुरुओं के सामने करना चाहिए, क्योंकि सुधारने का मौका भी साथ साथ मिल जाता है। So with this background, I coined the term, Swamiji, Ayurveda window in the house of medicine. It may look like a poetic topic, but the idea behind is that if a house represents a closed and circumscribed space, window is that part of the house which opens to the outside and brings in sunshine. With the sunshine comes new hope, new possibilities, new opportunities, and you never know what outcome can emerge from the possibilities that come from outside within that closed and circumscribed space which we are so used to living in. So that's my idea of calling Ayurveda the window in the house of medicine. And let us explore in the coming few slides, and these in fact are going to be very few slides. I'm not going to extend beyond the timeline in all possibility. So in the next few slides, we will see what opportunities we two fraternities can initiate together and what new collaborations we have between our two institutions in the field of Ayurveda. So students, it's not a talk, it's a story. So just feel relaxed. There is nothing to note down. Just enjoy the story that I am going to place in front of you. So it's a story about two schools. On the one hand, we have the Ayurveda system, which is the traditional system. As per my information, it is dating back to the 2nd century BC, but I am sure it is much older than that. And on the other hand, we have the allopathy system, which is the recent system, as recent as the 19th century AD. There has been a strong and complementary relationship between the two systems, and we know that more than 100 allopathic drugs like atropine, quinine, morphine, colchicine, digoxin, theophylline, and the list is endless. So more than 100 such allopathic drugs, so-called modern medicine, have their origins in the plants. And we are a uniquely advantaged country, having the traditional system in our backyard. And in the last few years, we have set up an extensive so-called modern medicine ecosystem, which has got more than 750 MCI recognized medical schools now, producing more than around 1 lakh medical graduates every year. So we as a country are uniquely poised to do the integration which we are talking about for the last 2 days. We have a unique convergence center of the two systems. So here in the next 20 minutes, what I am going to talk about is, I want to give you some illustrative examples. Some examples, the list is endless. Just a few examples of classical role of Ayurvedic preparations. And I'm not going to talk about metabolic disorders. I'm not going to talk about neoplastic disorders. I'm not going to talk about degenerative disorders. I will stick to my discipline, which is the infective disorders, and which I have not talked about a lot in the last few sessions. So I'll give you some examples of Ayurvedic preparations having conclusive evidence of working in infective disorders. And then I will talk about a potential for the combination therapy, which in fact is the theme of this conference, integration. So we'll give you some potential areas where this combination can take place, and we'll talk about the need for improved evidence in the form of trials and laboratory validations, which Professor Anurag sir was talking about in the morning. And lastly, we'll talk about the need of the hour. The only way forward is to do collaborations. So the favorite virus, my favorite virus is hepatitis B virus. Students, hepatitis B virus is a unique virus. All the viruses that cause hepatitis B virus is the only virus which is a DNA virus. All others are RNA viruses. Hepatitis B virus is the only living thing in the world which does not have a double-stranded DNA completely. One of its strands is complete and the other strand is incomplete. So it's called a partially double-stranded DNA virus. This virus, when it infects the hepatocytes, what it does is, it goes to the nucleus and it fools the hepatocyte, because the nature knows that DNA is always double-stranded. So when the nucleus of the liver cell sees this incompletely double-stranded DNA molecule, it thinks it is its own DNA that has got damaged, and it repairs that DNA. So what was an incomplete double-stranded DNA now becomes a complete double-stranded DNA. This is the problem why hepatitis B infection is a lifelong infection. You cannot eradicate hepatitis B, which you can do for hepatitis C. Hepatitis B, because its DNA we ourselves have repaired, made it completely double-stranded, and now it becomes a part of your genome. It becomes a part of the hepatocyte, and you cannot remove any part of your DNA with any medicine. So that's why hepatitis B is a lifelong infection. Hepatitis B causes lot of complications: chronic hepatitis, cirrhosis, hepatocellular carcinoma, apart from the acute hepatitis which we know about. So now there is a hope. The hope is in this is a very recent paper which was published in scientific reports, which is from the Nature group, and that's about our household curcumin. Please pay attention to each and every slide or each and every picture in this slide. What they did in this experiment was that they took modified hepatocytes in which there is a receptor which the hepatitis B virus uses for entering the hepatocyte. It's called this molecule called the NTCP, sodium taurocolate, which is the bile salt, sodium taurocolate co-transporting polypeptide. So hepatitis B virus uses this receptor for entering the hepatocyte. And what curcumin was shown to do was inhibit the entry of this hepatitis B virus by preventing its binding to the sodium taurocolate co-transporting polypeptide. Think about it. We have medicines in allopathy for hepatitis B. These come by a name called the nucleoside analogs. What these medicines do is they do not block the entry of the hepatitis B virus into the hepatocyte. Once the hepatitis B virus has entered the hepatocyte, these allopathic medicines, they prevent the replication of the hepatitis B virus. On the other hand, what curcumin was shown to do was it was preventing the entry, stopping the thief from entering the house in the first place, let alone do the burglary. So this is the wonder what curcumin was shown to do in this paper, which was published recently. And this is an immunofluorescence image of this paper. Here in a dose-dependent manner, you see here is the panel for 30 micromolar curcumin, where you see the red dots are hepatitis B viruses. And the blue ones are the hepatic cells, hepatocytes. You see at 30 micromolar, there is no hepatitis B virus present in that picture. That means complete entry of the virus has been stopped. That's a revolutionary finding. And if you see here, that molecule, if you remember, which I was talking about, the covalently closed circular DNA, which we ourselves have prepared, with 30 micromolar curcumin, you find there is no such DNA molecule in the image which is shown here with the curcumin. So this is conclusive evidence, mechanistic evidence, showing the evidence that yes, curcumin works logically by stopping the process in the first place, preventing the entry of the virus so that the downstream effects do not follow. This is the wonder what curcumin can do in hepatitis B virus. The next hepatitis virus that I would be talking about is hepatitis C. As I mentioned, hepatitis C is like the other hepatitis viruses, which is RNA virus. Now you have seen corona, you have seen influenza. The general rule is that RNA viruses do not enter the nucleus. They do all their life cycle in the cytoplasm of the cell. So that's why the hepatitis C virus, it can be cured. And that's again a marvel of modern medicine, that right now we have total cure for hepatitis C virus. It's not control. It's not lifelong medication to control the replication. It's cure. It's gone. The virus is eradicated from your hepatocyte. It's no more. That we have for hepatitis C. And hepatitis C, mind you, is a very big problem across the world, particularly with the onset of this opioid addiction, that opioid epidemic. The US is now currently going through opioid epidemic. Lot of young people, they have taken up opioid as an addiction, and with this injection drug abuse, the hepatitis C problem has again resurfaced. And in our country also, in the northeast, in the Punjab region, where we have got lot of intravenous drug abuse problem, there hepatitis C is a burning issue. Now there is a country, the Cameroonian country. So nowadays, the government of India has got a program called the National Viral Hepatitis Control Program, where hepatitis C drug is given free of cost. If you are diagnosed with hepatitis C, you get your treatment free of cost. These allopathic medicines are given free of cost. The problem with that is that hepatitis C virus is a very rapidly mutating virus, very rapid. So in the same infected individual, you have got lot of variants of hepatitis C virus. There are 6 genotypes, and within the genotypes also, there are a lot of variants. So that's called a quasi-species of hepatitis C virus. So every individual who carries hepatitis C carries in fact many such variants of hepatitis C, and you never know which of the variants will get mutation to hepatitis C drug that you are giving and will not stop responding to hepatitis C drug. So the dictum is that you give a patient the hepatitis C regimen, and then you follow him up after three months, 12 weeks. And if you still find hepatitis C PCR negative, you say that the hepatitis C is gone, and that's called sustained virological response, or SVR. Now, Cameroon is a country like ours, a sub-Saharan Africa, a country of limited resources. So what they did was they studied plant extracts from medicinal plants, and they studied these plants. I am not an Ayurveda person. I would not be very comfortable reading these names. But they studied 7 such fractions, and in these fractions, these three, F3, F4, and F5. So this F3 is some roots from Trichila, not be comforting. Let us, for the sake of convenience, let us call them F3, F4, F5. F3 is a root extract, F4 is a bark extract, F5 is a leaf extract. So these Cameroonian medicinal plants, you see here, so this again was a very conclusive evidence. So hepatitis C virus, it gets into the hepatocyte with its protein called the envelope protein. And in this experiment, what they showed was that once you have treated the hepatocytes with these plant extracts, the F3, F4, and F5, you find drastic fall in the number of hepatocytes that are infected with the hepatitis C virus. And if you give this plant extract before you do the infection, there is a sustained response. If you give the plant extract at the time of doing the infection, there is again a sustained advantage. But if, on the other hand, you give the plant extract at the time of this infection, then the result is not that promising. So that's about hepatitis C. In our own country, dengue and chikungunya, this is a study from the National Institute of Virology, where we have this chronic problem. Every year after the monsoons, we have got this dengue and chikungunya outbreaks happening immediately after the monsoons, mosquito-borne viruses. This dengue and chikungunya, there is no medicine as we have for hepatitis B, as we have for hepatitis C. There is no medicine for dengue and chikungunya. Dengue, on the other hand, is a serious problem, because in the second week of dengue fever, some of the patients infected with dengue virus, they have complications which are in fact inflammatory responses to the dengue virus that lead the patient to dengue hemorrhagic fever, dengue shock syndrome, and those are life-threatening complications. So in this study, what was done was these 3 compounds and these 5 extracts, these 6 extracts, they were studied for different strains of chikungunya and then for dengue. So this panel shows that these green cells, they are chikungunya infected cells. So there is no plant extract in this panel. These blue cells, they are virus-free healthy cells. But when you give this plant extract, M is a methanolic extract of some plant product, C is a chloroform extract. So these were found to work against the chikungunya strains, and you find that if you give 250 microgram of, say, this extract, there is only blue, no green. That means no virus. So this again is a conclusive evidence. We were talking of generating evidence. This is a conclusive evidence, real life image in front of your eyes, which show that this plant extract, it's not just he has said that this works. These are microscopic images say that if you give this plant extract, the virus does not get in. And similarly for dengue viruses, you see that this product called C8, at this concentration, there is no green, no virus, only healthy cells. That means this extract can prevent the virus from getting into the cell. So if there is no infection, then forget about complications. So those life-threatening complications like dengue hemorrhagic fever, dengue shock syndrome, those are taken care of if the cells have exposure to these plant extracts from beforehand. And the same thing is quantitative terms. This bar diagram show that in presence of these plant extracts, there is a drastic fall in the viral count. Coming to HIV, that's again a pandemic. That's been a pandemic since the 1980s. The entire world has seen we know high-risk behaviors, and this HIV is an interesting virus because HIV virus, like hepatitis C, it also is a virus that is capable of rapidly changing its form, mutations. Now, HIV virus, there are two broad kinds of HIV virus. One uses a kind of receptor called the CXCR4. Those are called the X4 HIV viruses. And there is another kind of HIV virus which uses the CCR5, another receptor. In short, it's called the R5 kind of HIV virus. So these two HIV viruses, so in this paper what was done was these three extracts. So this is Acuretus aspera. This is our rose, Rosa centrifolia, and this is this Ficus bengalensis. So the aqueous extract of this and the alcoholic extract of these, and it was shown that with these three extracts, they were found to have drastic effects on both the R4 and X4 and R5 strains of HIV, and they were found to reduce the infection, the entry of the HIV virus into in the cell culture system. Similarly, we know about COVID. These are very recent review papers. So there have been a lot of original articles on plant products in COVID and plant products claiming benefit against post-COVID complications, preventing the long COVID scenario. So in these are two systematic review papers which were published this year only, and there it was shown that there are two broad ways in which plant products can prevent the COVID infection into the cells with the ACE2 receptor. So either they can block the infection, just as we saw for hepatitis B virus and hepatitis C virus, they can block the entry and thereby the subsequent steps get prevented, or there can be an immunomodulatory effect where the products like this that are generated on the metabolism of this plant extract, they can prevent the downstream cytokine release and thereby the coagulopathy and the organ damage complications resulting from the hyperinflammation syndrome, they are taken care of, and thus the post-COVID-19 complications are taken care of. So this much about the viral infections I wanted to talk about. I want to touch upon bacterial infection because AMR is a global problem and we are really short of solutions. I want to describe this test, which is a litmus test kind of situation when it comes to testing your antibiotics against a particular bacteria. This test, you will find reference to it in every paper that says that this product works against this bacteria, this product kills this bacteria. So this test, the basis of that conclusion is this test called the disk diffusion test. Very simple, but that the simplicity has become its disadvantage. People take it very lightly. Imagine this plate, this circular plate, like a battlefield. In fact, not one battlefield. Consider each such section of the plate as one battlefield. There are three players in this battlefield. One is this battlefield, the ground on which the war is taking place, and there are two warriors. The ground is the media, this gray thing which you see, which is covering the plate, that's called the media, and on this media, you have got two players which are fighting against each other. One is this bacteria, the other one is this drug called the antibiotic, which you are placing at one point in the plate. If the bacteria wins, the bacteria goes right up to the antibiotic and you see no zone of inhibition. You say that the bacteria is resistant to that drug. If the drug wins, you see a clearing of the bacteria and you say that this drug kills the bacteria, hence give this drug to the patient. This is the simple principle, And the drug, what it does is when you place it on the media, it's an aqueous media, so the drug diffuses. The drug diffuses into the media. So very near to the disc, you get high concentration of the drug, and as you move away from the disc, the concentration decreases and decreases, and at a particular point, the concentration becomes so low that the bacteria is no longer killed, the bacteria grows. So we have a tendency to think that if you have wide zone of inhibition, it's very good drug, very effective in killing the bacteria. If you have a narrow zone of inhibition, not that good. If you have no zone of inhibition, doesn't work. So we have got a tendency to think in our minds that wider the zone of inhibition, more effective the drug is going to be, and that's a great mistake in interpretation that we do. Basically, the war is between not this, we cannot compare this antibiotic and this antibiotic from this test. We have to compare the drug and the bacteria only. We cannot draw analogy between two and comparisons between two antibiotics from this experiment. Please have this in mind. And this false premise has led to many false conclusions regarding, particularly also in allopathic medicines, but also in Ayurvedic formulation trials also. I give you some examples. So this paper claims that this Triphala and Triphala Mashi, the aqueous and the alcoholic extract, you just see what they are comparing. They are comparing between different extracts just by the zone of inhibition, and greater the zone of inhibition, they say, more effective is the drug. Another paper, again on Triphala, you say 100 microgram per ml, and they say that this one is the best because it has produced the highest zone of inhibition. This drawback, this wrong conclusion, we should be mindful about. Similarly, this drug, this Tinospora cordifolia, it says it kills carbapenemus producing bacteria just by showing that you are getting growth inhibition in presence of Tinospora cordifolia for the MRSA or the carbapenemus. So I want to caution you against these false interpretations. So can we improve on the evidence by understanding the science? The science is that this drug works against this antibiotic, drug acts against this bacteria, and the interpretation for that is reliable, reproducible if the methodology is robust. By robust, we mean that there has to be procedural standards. The composition of the media has to be unchangeable from batch to batch. The amount of bacteria you put on the plate has to be standardized. The antibiotic disc that must have a quality controlled, reliable concentration of the antibiotic, which we unfortunately do not have to the best of my knowledge for Ayurvedic formulations. We do not have those discs, and we do not have the QC parameters. The disc can lose the antibiotic if it is not stored properly. So the allopathic medicines, their discs, they come with certain defined ranges. If the antibiotic is working against this quality control strain of E. coli, there must be this much zone of inhibition. That is available for them, but not available to the best of my knowledge for Ayurvedic formulations, which we need to work on. And on the basis of this, we have this, it is no point saying that this drug works because it produces 15 mm zone of inhibition. There are categories which are defined by these results, the in vitro results, the PK/PD studies, along with the clinical studies, and then we have got 3 criteria mostly: whether the drug is susceptible, whether the bacteria is susceptible to the drug, or the bacteria is resistant to the drug, or it is intermediate. Now, let us take an example. So this is a drug called Augmentin, and this is a drug called Cefotaxime. For Augmentin, they say for example, in an experiment you got, the zone of inhibition is 18 millimeter, and for Cefotaxime it is 21 millimeter. So you'd be inclined to think that Cefotaxime is better because it is producing a zone of inhibition which is wider. But if you look at the charts say for Augmentin, anything more than 18 is susceptible, and for Cefotaxime, anything less than 22 is resistant. So though apparently it appears that Augmentin is better than Cefotaxime is better than Augmentin because the zone of inhibition arithmetically is larger, but actually It is cefotaxime which is going to be resistant and augmentin which is going to be sensitive because the standard charts say so. So what I want to say is, what I want to leave a thought with you is that when we say this herb inhibits carbapenemase producing bacteria, can we document? We have got ranges, quality control defined ranges for susceptibility and resistance for carbapenems. Can we show that this H, when given along with this carbapenem to the bacteria, it brings the MIC of carbapenem down to the susceptible range? If we show this experimentally, then it will be a conclusive proof that yes, this herb H works against carbapenemase producing bacteria, because we are explaining them in their terms using their reference ranges, that see, my herb works because your parameters are being satisfied. So this kind of evidence we want to generate if we want to say that our herbs are answers to the growing problem of antibiotic resistance. Swamiji, I'm just short of time, probably I'm probably stretching a bit. Swamiji, this one I wanted to bring to your notice that herbal medicines and allopathic drugs, there can be two kinds of interactions. We do not know. It's not that every herb will have a synergistic effect or an we need to do it. We need to experiment it. We need to prove it. So if it is a synergistic effect, it will bring benefit to the patient. If a lower amount of allopathic medicine can be given, if it is co-administered with an herbal drug and it has a synergistic effect, it will be a therapeutic benefit. If on the other hand it's antagonistic, it will do adverse effect, and the basis for that is pharmacokinetic and pharmacodynamic interactions between the Ayurvedic and the allopathic medicines. And there have been very few studies, experimental studies on such interactions, and even fewer human studies. And this paucity of evidence on the comparative effectiveness, allopathic works better or Ayurvedic works better? Do they work best when they are together, or presence of one with the other do a harm? This kind of studies are we need to do, because they are easier to do than generating the evidence completely brand new. And these studies need to be done with the currently available Ayurvedic prescription formulations rather than the pure extracts or the compounds. The herbal formulations that are being sold, we need to test them along with the allopathic medicines to demonstrate the kind of synergistic or antagonistic effect that they have with each other. And I'm happy to report that we are doing this kind of studies at AIIMS Bhopal. We have got 2 diabetic rat model and another model, rat model of dyslipidemia, where we are doing this kind of interactive studies between the commercial Ayurvedic formulation and the conventionally given allopathic formulations. And this kind of study, we think we should increase in numbers. So this interaction study needs now to be extended to anti-infectives. We have seen what infection can do in the last pandemic. Infection can hit you anytime, infection can hit anywhere. And we need to increase our armamentarium to anti-infect in the form of anti-infectives, and the pipeline is not very strongly flowing. So we need to extend to anti-infectives, and this is the last slide. I leave you with 2 thoughts. If can we do this kind of synergistic interaction study between Ayurvedic formulation and antibiotics, the Kirby-Boyer disc diffusion plate, simple experiment that I showed you. Can we do in vitro studies and show that presence of Ayurvedic formulations lower the MICs of resistant antibiotics? That will be a conclusive proof that we have got an answer, some answer to the AMR problem, which is a growing problem every day. Can we do PKPD studies to show that if you co-administer Ayurvedic formulations, you increase the bioavailability of some allopathic drugs, and that also will lower the dose requirement of the allopathic drugs? And finally, can we do clinical studies that given this in vitro result, given this PKPD result, it also translates in terms of clinical benefit? So this kind of studies will show in the area of antibiotics, And similarly, in case of antivirals, as I said, in case of hepatitis C, we have got allopathic medicines. It cures the virus, it eradicates the virus, but it has got a long duration of treatment. And after you have given that long treatment, you wait for 3 more months to know whether there is a response or not. So can co-administration of the Ayurvedic formulations lead to increased rates of SVR? Can this lead to shorter duration of therapy? Can it lead to reduced cost of treatment and thus increase patient compliance? And can the immunomodulatory effect, which we know certain plant formulations have, can reduce the inflammation-mediated damage of viral infections and thus lead to reduced clinical severity? I end my talk with these thoughts, and I hope to work together with this great institute, which I had the opportunity of knowing in the last 2 days. Thank you very much.
Dr. Biswas, just one quick comment. I think you made a fantastic presentation, and we are very happy and thankful to you that you put good efforts to show what are the lacunae and where things can be worked out. On the same theme, I would like to also inform that microbiology team at Patanjali Research Institute have been working on the same themes. And we do have indeed data on all the areas that you talked about, including your last slide where you showed that what can be done where we synergize the modern medicine system with Ayurvedic sciences. So we have data where we could show that the bioavailability of existing drugs or antibacterial goes up when we have Ayurvedic drugs present to it. And if we can modify the MICs and other things, Dr. Swati, who's next speaker, would be talking a little bit about the same.
That's great, sir. I highlighted this point because that is a low-hanging fruit.
Absolutely.
Which we can approach very easily.
Right, sir.
If we want to generate our references, say for example, I showed you that slide which says that if you want to say that this bacteria is sensitive to augmentin, you need to have a zone diameter of 18 mm. That kind of generating that kind of chart for these thousands of Ayurvedic formulations is going to be a mammoth effort. We need not do it now. We need not do it now because ethically to do that kind of trial will also be challenging because you have existing solutions. How can you deprive a patient of such solutions? But what we can do advantageously and what we can do with lesser investment of time and effort is do these synergistic studies, interaction studies, and that is why I highlighted that part only. It's great Patanjali is doing it already. We will be more than happy to join hands.
Absolutely, sir. Thank you very much indeed.
Thank you very much, sir. Moving on to our next speaker, may I invite Dr. Swati Haldaji, who will be giving her talk on evidence-based